Hi, this is Callie, and this is my presentation on vulvar cancer. We're going to look at the objectives, and those would be to discuss the pathophysiology of vulvar cancer, discuss the common presentation, the potential differentials that we could find, red flags and actions needed to identify and treat the patient, discuss the important history and physical findings that we'll find when we look at patients with vulvar cancer, and then also the diagnostics, potential management, and treatment options for patients diagnosed with vulvar cancer. And then at the end, we'll talk about the patient education that can be provided and the follow-up care that these patients will be needing. So when we're going to look at vulvar cancer, or I can call it VC during this time just for time's sake, we're looking at the outer vaginal lips, and less often this cancer affects the inner vaginal lips, clitoris, or vaginal glands. And usually forms over a number of years, and abnormal cells can grow on the surface of the vulvar skin for a long time. And this condition is also called vulvar intraepithelial neoplasia. In up to half the cases, HPV infection appears to have the most important role. So VC cancers associated with HPV, which include the basaloid or warty subtypes, seem to have a certain distinctive features. They are found along several other areas of the vulvar intraepithelial neoplasia. And early studies analyzed tissue samples from about 48 patients with vulvar cancer. And when they looked at whether it was by HPV or not, they're finding that about 96% of the cases were subtypes 16 and 18, and an estimated 80% of the untreated women suffering from the vulvular intraepithelial neoplasia had developed this cancer. So this type of vulvar cancer, the VIN, or the vulval intraepithelial neoplasia, is quite seen in these patients, and you're going to see this in the 35 to 65 years of age. And a recent review pointed out that approximately 15% of all vulvar cancers develop in the women under age 40. And they're looking at the predisposing factors of STDs in the past, low economic status, or nicotine abuse that have also been found. The second type of vulval cancer is non-epithelial disorders, and this is due to advanced age that lead to cellular atypia and eventually to cancer. So elderly patients from 55 to 85 years old in particular have a slow rate of HPV infections and consequently seldom any association with cervical neoplasia. So like diabetes mellitus, hypertension, and obesity seem to correlate with the incidence of VC, but they don't always seem responsible at this time. Lichen sclerosis, a subgroup of VNDE, or the non-neoplastic epithelial disorders, is seen as a predisposing risk for the development of HPV negative vulvar cancer. And because the severe pruritus caused by the lichen, it leads to squamous cell hyperplasia, and over time a progression to atypia, followed by VIN and eventual invasive cancer. So this infection is much worse than the HPV one, and so we want to make sure that we catch this early. So another process that we see for VC cancers and that does not develop into HPV infection, these vulvar cancers not linked to HPV, and are usually diagnosed in the over 55. And as we talked about, this was the lichen sclerosis, and they also may have a differentiated type of VIN. And they're looking at these mutations of the p53 tumor suppressor gene, and they're saying that this gene has something to do with the cells from the VC becoming cancerous. And so when the gene undergone the mutation, it's easier for the cancer to develop. And the younger vulvar cancer patients with HPV rarely have this mutation. So they're finding this in the older patients. So when we're looking at the common presentation that we're going to see with VC, it's the fourth most common gynecological cancer and contains about 5% of all malignancies of the female genital tract. So after cancer of the uterine corpus, ovary, and cervix. So there are several histological types, whereas like squamous cell carcinoma of the vulva is the most common of 95% of them, followed by melanoma, sarcoma, and basaloma. The survival rate and relapse time correlate with specific histologic growth patterns, as explained. And then the prognosis is good if it's caught early. So as we're doing this with these patients, we want to make sure that we're talking with them and looking during exams and seeing if there's anything abnormal. So the most common described symptom of VC is a long history pruritus. So we need to make sure that anybody that has long-term itching that has not been resolved after medications or that continues to be very itchy, we need to make sure we take a better look at that. Less frequency, we're going to see the vulvar bleeding, dysuria, discharge, and pain. The most obvious manifestation of a VC is a valvular lump or mass, and this may present as ulcerated, fleshy, or warty. So many patients, they do have the itching, like we talked about, the long-term itching, some burning, some bleeding that may go away, that's from the vulva. Changes in the color of the skin around the vulva, so it either looks redder or whiter, and so you want to make sure that you're looking at that and seeing if that's okay, like if that's a normal thing for that patient or if that patient has something else going on. Skin changes also, rash or warts by the vulva, sores, lumps, or ulcers that do not go away by the vulva. That's something that you really need more we're looking into. And then pain in your pelvis, especially when you urinate or have sex. So if someone's having an ulcer, if they're having a problem with the VC, you're going to be seeing some kind of pain when there's rubbing in that area. So saying that those symptoms are kind of broad, you're also going to be looking at the differentials. The differentials for VC can include boils, cysts, or abscesses. Paget's disease, which is kind of another cancer of the vulva, ulcer, and Bartholin's cyst. So the symptoms of a boil is, I don't know if many of us have ever had any or seen them. So you're going to see a patient with a swollen red lump deep in the skin, and sometimes hair will grow from it. It's also painful, especially when touched. And in certain places of the body, such as like the nose or the ear, or even in the vaginal area, you're going to see this. And it can vary in size from pea to golf ball, and it may develop a central whitish head that may break and release pus. So these things can weep, ooze clear liquid, or even yellowish to green if infected, and develop a crust. And it also may spread to surrounding skin, creating a carbuncle. And this is not normally found on the vulva. So if we're looking at that, if it's close to the vulva area, normally we're not going to find that. So could be a differential, but we're looking if it's on the vulva, most likely it's not a boil. Paget's disease is commonly seen in postmenopausal Caucasian females and appears clinically as red eczemas and sometimes painful lesions. So we talked about with VC, it's not very painful all the time except for with certain activities like sex or urination. As the Paget's disease, as we're talking about, in most cases, it's intraepidermal adenocarcinoma, in which tumor cells involve in the epidermis and sometimes the underlying skin of the appendage. But sometimes their focal dermal invasion, depending on the age of the patient, will determine if the diagnosis can be appropriate or not. So if the patient's under the postmenopausal age, this may not be something that we consider. We can also look at vulvar ulcers, in which that can be from an active infection from either HPV or syphilis. The disease is characterized by the onset of flu-like symptoms with a single or multiple painful ulcers on the vulva. Diagnosis is mainly clinical after exclusion of all the other causes of vulvar ulcers. The treatment is mainly symptomatic, like we talked about, and with spontaneous resolution in 2 weeks without reoccurrences in most cases. So if this is something that we're monitoring, it goes away, this is most likely not VC. And then we have Bartholin's cysts that usually do not cause any problems, but abscesses can present with severe pain and can cause discomfort, typically during ambulation, sitting, sexual intercourse. Fever may not always be an associated feature, and on examination, we're looking for warm, tender, soft, and fluctuant mass in the lower medial labia majora. It may occasionally be surrounded by erythema and edema. Large abscesses may be expanded to the upper labia, and the most common types of these masses are cysts or abscesses. So we're looking at that. You're looking at the dilation of the duct following the blockage of the duct opening. And the obstructive duct can become infected and form an abscess. And abscesses are 3 times more common than cysts, and women in the reproductive age are more likely to develop these Bartholin abscesses. and they mostly appear in women at risk for STDs. So you're going to be looking for this in the differential between VC and Bartholin glands. Most times you're going to see they're not really on the vulva. They're going to be in the lips of the vagina. They're going to be a larger mass, and it's going to be kind of something that happens over time, like not over a long period of time. You're not going to see as much itching, and so that can help rule this out also. So when we're going to be looking at this, there's red flags that we need to know about, and the red flags kind of help us narrow down our diagnosis, and then also maybe look at possibly what we would need to do next. So the most common described symptom of vulvar cancer is long history of pruritus. And so less frequently reported symptoms of as we talked about, the dysuria, the discharge, the pain. And the most obvious manifestation of vulvar cancer is a vulvular lump or mass that may present ulcerated, fleshy, or warty. So if you remember that, this will be helpful. So squamous cell carcinoma accounts for 95% of these and we're going to see them in three main categories. So the warty, basaloid, and keratinizing. The predominant type is the keratinizing, and accounts for 65 to 80% of the vulvar squamous cells. The basaloid and warty types of squamous cell account for the remaining 20 to 35. And the keratinizing type is normally in the postmenopausal women. The warty basaloid tends to be in premenopausal or perimenopausal patients. And then this one, the keratinizing type, is usually formed by well or moderately differentiated cells with absence of coiled cytosis. So then when we're looking at the warty and basaloid types of squamous cell, there's also associated with VIN. So as we talked about that earlier, the basaloid type typically grows in bands or sheets or nests with a desmoplastic stroma, and a focal cytoplasmic maturation and keratinization may be observed. So the warty type exhibits invasion of bulbous or irregular jagged nests and often prominent keratinization. As you can see in the picture on this slide 6, there's a couple examples of some cancer and also the bulbous that you're seeing. A vulvular melanoma is the second most common neoplasm of the vulva, and the majority of lesions that involve the clitoris are labia minora. Any pigmented lesion of the vulva should be excised for diagnosis unless it's known and unchanged for many years. So this is something that if you are watching and hasn't changed, then you're fine. So if we're looking at this and we're looking at the red flags, so like we talked about the long-term pruritus, the non-tenderness, sometimes they're indurated white lesions, frequent yeast infections, so that we want to rule that out, or if that person has frequently yeast infections, are they being resolved by the treatment that we're giving them, and atrophy. So we talked about that earlier. Sometimes the older women in past postmenopausal and can run into this because it's not related to STDs. So if we're looking in that, it's important to start diagnostics early because it can improve the outcome for the patient. So as we talked about, the important physical and history, again, is the long history, a lump or a growth in the vulvular area or groin, an ulcer that persists for more than 1 month, or wart-like growth similar to genital wart. So when we're doing our Pap exam and when we're doing exams on any patient, regardless of age, we're looking for these main items. So if something is not supposed to be there, or this has been something that is new for this patient, we really want to make sure that we're documenting that and really following up on that. So if this is new for that patient and we really need to follow up on it, what would we be doing for that? And so we'll look at the diagnostics, and really the beginning part of any diagnostic is looking at a physical exam and history. And this exam is to check general signs of health, including checking the vulva for signs of disease, such as lumps or anything that seems unusual. And a history of the patient's health habits and past illnesses treatments will also be taken. So if we know that this person has never been vaccinated for HPV, if we know this person has had STDs in their background, we're going to be looking at that and saying, okay, is this a possibility for this patient? If this is suspected, we're going to be looking at a biopsy. And a biopsy is a removal of the samples of cells or tissues from the vulva so they can be viewed under a microscope to check for signs of cancer. And so this will come back whether negative or positive for those cells. We also can use CT once it may be a preliminary diagnosis or a possible diagnosis is found maybe possibly through that biopsy. And this will create a 3D image of the inside of the body using x-rays from different angles. And so this can be used to measure like the tumor size. Sometimes a special dye can be given. Usually for people with the vulvar cancer, you're looking at maybe how if it has gone somewhere else down in the vagina, or if we're looking at it metastasizing somewhere. And that's where we're going to go into the positron emission tomography or the PET scan. And this is usually combined with a CT scan, like we talked about. And you're going to see like a small amount of radioactive sugar substance is injected into the patient's body. And the substance is taken up by cells that use the most energy, because cancer cells tend to use the most energy and absorbs the radioactive substance. And this will also look and see if it has spread anywhere throughout the body. We can also use the MRI, and this uses detailed images of the body, can measure the tumor size, and then it also can give a clearer picture too. And lastly, we can use an X-ray. There is a type of energy beam that goes through the body onto the film, making the areas inside the body able to be seen. So this is to use to stage a vulvar cancer, and they may be taken to look around the area and see if it's spread. There are some people that have set a CBC just to check around to make sure there's no infection in the body to rule things out, but I did not see much I guess, evidence to support that. So then what happens if you do get diagnosed with vulvar cancer? What would we do? So we're going to look at the management of VC. And so knowing the stage of VC helps the doctor decide if the additional treatment may be necessary and can help predict the patient's prognosis, which is the chance of recovery. So there are different stage descriptions for different types of cancer. So for VC, the staging system has been developed by FIGO, or the International Federation of Obstetrics and Gynecology. So doctors will assign the stage of cancer by evaluating the tumor and whether the cancer has spread to lymph nodes or other parts of the body. So stage 1 is the tumor is only in the vulva or the vulva and the perineum, but it has not spread. So you have stage 1A, which is the tumor is only in the vulva and is 2 centimeters or smaller, has not spread, is no deeper than 1 millimeter. And then you can also stage it as a 1B, which is no larger than 2 and is deeper than 1 millimeter, but only in the vulva or the vulva and perineum together. If the tumor is larger, we're going to move to stage 2, and this is a tumor of any size and has spread to nearby structures. So this includes the lower part of the urethra, the vagina, or the anus, and it's not spread to lymph nodes at this time or any other parts of the body. By the time it reaches stage 3, the cancer has spread to nearby tissue, such as the vagina, anus, or urethra, and to the groin lymph nodes. So this is something where we want to catch it early so we don't have this lymph node involvement. So which with stage 3A, the cancer has spread to nearby tissue, the vagina, anus, or urethra. There are 1 to 2 metastases to lymph nodes, but they're smaller than 5 millimeters. And there's 1 metastasis that is 5 millimeter. There's no distant metastasis. With 3B, the cancer has spread to nearby tissue, like again, the vagina, anus, or urethra. There's 3 or more metastases to lymph nodes, but they're smaller than 5. And there's 2 or more metastases that are 5 centimeters. And there's no distant metastasis. Everything's still staying down in the vaginal area. With 3C, we're going to see the cancer has spread to the nearby tissue and to 1 or more lymph nodes and their surrounding node capsule or covering, and there's no distance, so it hasn't left the area. In stage 4, the cancer has spread to the upper part of the vagina or upper part of the urethra, or it has spread to a distant part of the body. So in stage 4A, we're looking, the tumor has spread to the upper part of the urethra, vaginas, or anus, and it has spread to regional lymph nodes and caused ulceration. And it's attached to the lymph node to the tissue beneath it, and there's no distant metastasis. And on 4B, the cancer has spread to a distant part of the body. So this ranging system and this staging system is really going to help just determine how we are going to handle that and what kind of treatment we're going to give to those patients. So if we go to the next slide, we're going to see that. So treatment for vulvar cancer depends on the staging of the cancer. So treatment should be tailored to the patient and what should be the best possible chance of recovery. So if we're looking at the treatment of vulvar intraepithelial neoplasia, or the VIN, we're looking at removal of the single lesions or wide local incision, laser surgery, ultrasound surgical aspiration, skinning of the vulvectomy without or with a skin graft, or biologic therapy with topical imiclinimide. So then if we're going to talk about treatment for stage 1 vulvar cancer. And this is both for both the A and B type. This is a wide local incision for lesions that are less than 1 millimeter deep. Radical local incision or removal of nearby lymph nodes, radical local incision and sentinel lymph node biopsy if cancer is found in the sentinel lymph node, and nearby lymph nodes are also removed. And then radiation therapy for patients who cannot have surgery. So really the surgery is the number one thing that they would like to do, followed by the radiation and the chemotherapy. And then when we go to stage 2 VC, you're looking at a radical local incision and removal of nearby lymph nodes, modified radical vulvectomy or radical vulvectomy for large tumors. Nearby lymph nodes may be removed and radiation therapy may be given after surgery. Radiation local incision, radical local incision and sentinel lymph node biopsy if the cancer is found in the sentinel lymph nodes. And radiation therapy for patients who cannot have surgery also with this type. As we climb to stage 3, we're going to be looking at a modified radical vulvectomy or radical vulvectomy. And this involves the near lymph nodes that may be removed, and radiation therapy can also be given. Radiation therapy or chemotherapy and radiation followed by the surgery. And radiation therapy or with or without chemotherapy for patients who can't have surgery. So it really kind of encompasses like everybody. If you have VC, they're always going to be able to treat it or you do something to help it. So stage 4 vulvar cancer, we're looking at a radical vulvectomy and pelvic exoneration, radical vulvectomy followed by radiation therapy, and radiation therapy or chemotherapy and radiation therapy followed by surgery. And then you're also looking at radiation therapy without chemotherapy if you cannot have surgeries. So there is no standard treatment for the stage of 4B vulvar cancer, but treatment may include a trial of a new medication. And then there is biologic therapy. This is a treatment that uses the patient's immune system to fight cancer, and substances made by the body and is made in the laboratory to use to boost the body's immune system and natural defenses against cancer. This type of treatment is also called immunotherapy. And so we're looking at that imiquimod that I had talked about earlier, and it's a biologic therapy that may be used to treat the vulvar lesions and is applied to skin in a cream. So this is something that without surgical that someone can try. The only thing is sometimes that VC will come back even after it's treated. And so when we're looking at the treatment of VC after that, so we're looking at a wide local excision with or without radiation therapy to treat cancer that has come back in the same area. A radical vulvectomy and pelvic exoneration to treat the cancer that came back in the same area. Chemotherapy and radiation with or without surgery. Radiation therapy followed by surgery or chemotherapy. Radiation therapy as a palliative treatment to relieve symptoms and improve quality of life. And eventually, if it continues to come back, we're looking at a clinical trial of a new treatment, hopefully, for these patients. So what should we teach the patients about VC that would help them? So when we look at this, we're looking at prevention tips to help this patient keep themselves from getting VC, but maybe can help themselves from the reoccurrence. So the prognosis of patients with VC is quite good when convenient treatment is provided in a timely manner. So inguinal or femoral node involvement is the most significant prognostic factor for survival in patients with VC. Extracapsular growth of lymph node metastasis, 2 or more affected lymph nodes, and more than 50% replacement of lymph nodes by tumor are predictors of poor survival. So the overall 5-year management rates from 70 to 93% for patients with negative nodes, and from 25 to 41% for people with positive nodes. So we're looking at vaccines that protect against certain types of HPV infections are available. So all of them protect against the infection with HPV subtypes 16 and 18, and some can protect against infections with other HPV subtypes, including the types that cause anal and genital warts. These vaccines can only be used to prevent HPV, and they do not treat an existing infection. So to be most effective, the vaccine should be given before the person becomes exposed to HPV or like sexually active. And all these vaccines can prevent cervical cancer and precancers. And they're also approved to help prevent anal and genital warts as well as other cancers. So this is really important for the prevention of VC, that we talk to patients early and we talk to family members early about getting the HPV vaccine. Patients should also be advised to quit smoking or never to smoke, as it increases the risk of vulvar cancer. It's also important that you see your healthcare provider for any problems that come up between checkups. Symptoms including vulvar itching, rashes, moles, or lumps that won't go away caused by VC could be precancer and should be checked out. So if VIN is found, treating it might be prevent invasive squamous cell vulvar cancer, and some vulvar melanomas can be prevented by removing atypical moles. So if you have a mole in your vaginal area or by your vulva, it would be important to get that checked out by your healthcare provider. The vulva also is examined at the same time as the patient has a pelvic examination, so we really need to be making sure that people are following up on their pelvics and paps and that we are keeping up with them. So cervical cancer screening with a pap test and sometimes combined with a HPV test is often done at the same time. For most women, the best way to find VIN and VC is to report any signs and symptoms to the healthcare provider and have a yearly well woman exam. So if you're at an increase for vulvar cancer, you may also want to check your vulva regularly and look for any signs of cancer. So we can also teach people how to look down at their vulva and see if there's anything going on, if there's anything out of the ordinary, and that way they can maybe help themselves notice if anything's wrong right away. And really following up with a healthcare provider and completing recommended treatment can improve the patient's outcomes. So like getting the HPV vaccination, stopping smoking, making sure that they are not contracting any STDs, and then also if their staging is correct, and then following up what the treatment recommendations were for that patient. Following treatment plans, even though it is scary with the chemotherapy and the radiation, this is the best chance that these patients have to live if we can keep it from the sentinel lymph nodes and keep it from entering the rest of the body. So what are we going to do for follow-up care for these patients? So once they're diagnosed and then we actually are saying, hey, you're cancer-free at this point, what are we going to do for them? So when we're looking at that, we're looking at the follow-up with most cancers, including VC, is based on a custom and practice that of what we want to do. So up to a third of vulval cancers will recur even after satisfactory primary treatment. So this is really important that we have patients follow up and we have a follow-up plan for them. So as salvage is largely dependent on either the further excision or radiotherapy, recognition of reoccurrence as early as possible seems logical. So for this reason, I found that many of the regimens are every 3 months for the first year, 6 months for the second year, and yearly thereafter. Though there is not much data to support that approach, I do feel like that's important since the reoccurrence rate is pretty high. Late recurrence is unusual, but it's encountered, so follow-up should be required for many years. And in addition, patients be advised to bring forward their review if they experience any new symptoms or if the appearances of the residual tissues change anyway. So while elderly and frail may find it hard to self-examine, we really want to make sure that we're talking to those patients, saying this is what we see right now. If this changes, we need you to come back in. Please come see us so we can make sure that we are on the right track and that we are treating you and keeping up with how everything's going so it doesn't spread anywhere else. So to recap, we're looking at vulvar cancer being relatively rare. It's one of the lowest cancers, as you can see on the number of cancers attributed to HPV. It does rank number 4, but it is not a very high diagnosed amount of cancer. The main symptom that we need to remember is a long history of pruritus. So yes, someone may have a long history of yeast infections, but we also then want to start considering, is there something else going on if these are not resolving with medications, or if there's something else going on, if it is even resolving with medication, maybe there's another factor that's playing into it. So we really need to make sure we're doing thorough examinations. Patients can be treated through multiple methods, with surgery being the main intervention. So if we're looking at that, so the number one thing that we want to do is prevention in the first place. But number 2, we need to make sure we stage appropriately. And 3, we have to catch it early. So the vulvectomies to the biopsies to the ensuring that we get the cancerous area off the vulva, we can really help that patient in the long run. catching it early can lead to a better prognosis. And that's true because if it spreads to our lymph nodes, it's going to be metastasizing to somewhere else in our body, leading to more unnecessary treatment for cancer and possibly having a worse prognosis. And then importantly, we need to encourage vaccination of HPV and reporting of symptoms early. So talking to those patients about getting the proper vaccines, making sure that they are using condoms, make sure they are using different barrier methods so they are not getting STDs, making sure that they are looking down their vulva, making sure there's nothing else going on. If they notice a different mole, if they notice any more discharge, if they're noticing that there is pain when there's urination or pain during sex, this is not something that's always common, and it's okay to come talk to us about it because we really want to catch this early so we can treat it early and not have to worry about worse outcomes down the road. So as we go through, that is my presentation on VC. I will be posting the questions in the discussion board. I appreciate your guys' help this week, and I look forward to meeting you guys in the discussion board. Thank you, and happy 4th of July. Bye.